Hi, my name is Dr. Brendan McCarthy. I'm the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you so much for tuning into the podcast. As always, I have been looking forward to this moment all week long. I love doing these videos. It's a highlight of my week. It really is. It gives me a chance to sit down and kind of reflect on aspects of practicing medicine that I do every day. I am so used to this. It's just part of me, and you do something all the time. It's one of those things you're just so used to doing that you don't always get a chance to reflect on it. This is what you do all the time. And I love my work because it's very rewarding. The benefit that I see in the patients that I care for, the feedback, the relationships that I build with my patients is a very dear thing to me. And it's, I think, unlike any other career I could have chosen, to be honest with you. Even in the healthcare industry, I think this is unique what I do. I feel very, very blessed for it. And so when I sit back and I reflect on it, especially on today's topic, today we're going to talk about testosterone in women. I've talked about it before, and I promise you I'll talk about more. And I'll continue making videos on this. And I'll continue doing everything in my power to be helpful for you on this. I promise you. So today's video, specifically, I'm going to go into the nuts and bolts of using testosterone in women. And previous videos I just did were more about the why and the benefits and some of the concerns around that and some of the things we watch for. Today I'm going to get into more of the nuts and bolts, very specific. I'm going to get into dosing. I'm going to get into the labs. I'm going to get into the concerns we have, the delivery systems. I'll do my best. I have Evelyn here with a stopwatch. She's going to stop me at a certain time so I don't go too far because I tend to do that. I'm going to have citations, in on the YouTube channel. You see in the description, there'll be some citations in there. I think that's important to cite my work for you because this is a scary thing. No matter what people say, testosterone is always going to be a tricky thing to use in clinic, literally every single time. And if it isn't, they're not doing it right or they're not paying attention. I'm going to make sure you understand exactly why. I'm going to do a good job being clear with that. It's just that it's a very tricky thing. And because it's tricky, there's a lot of fear. And that fear is valid. It is valid. If I don't do the right dose and what happens, and women out there, there's fear because, one, there could be the fear that you've never heard of another woman using testosterone before. You're the only person in your community that you know of that's ever been prescribed testosterone. You're always going to feel weird. You don't have a sense of community. You don't know who else has done this. What do I worry about? What is this normal? So that's a scary thing to be. I'm dealing with a patient right now who's going through that, and it's different because where I live, there are so many women that use this therapy. This is a common type of therapy here. This is enough people do it where you're saying my doctor prescribed me testosterone. The woman at the next table over at the restaurant, yeah, me too. And it's you don't feel as alone, and you guys can talk to each other. You just feel a sense of community that way. You don't feel as out on your own, a little nervous. Then there's other cases where women who are already currently taking testosterone and medicine's not good. Okay. I say this a lot. I'm repeating it. Medicine is not good in the sense that there's a profound lack of follow-up care and monitoring. And there's always the fear that what you're doing may cause side effects that are significant. There is the fear that the benefit that you're experiencing, because those of you who are doing this, you know how good this can be, how amazing this can be. But if you're doing this and then in the back of your head's like, what if there's side effects here? What if there's something happening in the background where all of a sudden the side effects get so profound, I can't continue this therapy? There's a lot of fear that you'll lose the benefit of the therapy because of side effects. And these are all valid things. I want you to know that in 20 years of practice prescribing and working with this, I have seen a lot and I want to share all of it with you. I am very comfortable prescribing testosterone because of all these years doing this. I know what to expect, what to look for, how to lab, how to monitor, how to dose, how to care around that. I'm going to do everything in my power to share that with you. I know there are a lot of practitioners out there that are just now adopting these types of therapies in their practice, and God bless them. I love that. I think this is great. A lot of them are just getting it out of a book or a weekend seminar, or they're just doing their best to figure out the woman in front of them, and it comes from here with them. And I'm not doing these videos to be critical of those practitioners. I'm doing these videos to be supportive and of you and to empower you further. The goal is to give you as much information as possible, to be as helpful as possible. To the degree I do that, I'm successful. To the degree that I'm not, I want to know. This series, these videos, everything I do, as you'll notice, I'm fond of saying this, I don't sell you things. I don't need to. I'm fine, and I'm not soliciting you to come and see me in my practice. I'm good. I'm not doing this to make money, to be honest with you. I love my work. I'm in a place where I can do this because it's something that brings me joy. And there is a benefit, by me spending time on this and reflecting on my work. It helps me recenter and reflect and even improve upon myself as a physician. So this does give me benefit in there. I want you to know that. I spent a lot of time researching, getting ready for these, and that is a very useful thing to do with my time. So it does go both ways. Anyway, let's get into the material. The symptoms, as I mentioned before, I'm going to reiterate again, the symptoms we use testosterone replacement therapy for is going to be low libido, low energy, memory loss. Sometimes you can consider weight gain in there, depending. If the weight gain is not associated with diet, you just do diet figuring out. But so weight gain, why I'm saying weight gain is because loss of muscle mass. If you're not, muscle mass is diminished, it's difficult to maintain body weight. So again, that goes back to that muscle loss component. Loss of bone density, that's another one. Depression, that low sense of well-being, decreased motivation for change. In other words, stress incontinence. And then finally, estrogen dominance that's not being well managed with just progesterone. These are the symptoms I generally use in clinic for testosterone for women. These are the ones that I have the most benefit for them. Once I had that idea of her symptoms and I see her lab work showing it being low, and this is the part that gets tricky. So let me talk about lab work now. Lab work is going to be the most difficult thing to use with testosterone for women for several reasons. One is that there's no real accepted reference range that's broadly accepted for testosterone for women. It's I see different lab companies have different reference ranges. And also I see different lab companies have different methodologies of testing, which makes it very difficult to work with. If you're in the States, I use LabCorp or I use Access Medical Labs. That's in Jupiter, Florida. Amazing lab company. I've used them for a very long time. Think very highly of them. These are the people I use primarily. Quest, I avoid. I don't do saliva testing. I don't do urine metabolites for testosterone. I generally use serum. The bulk of research on testosterone replacement therapy in women of what we have goes on serum testing, and so I use the blood work. When I run a woman's labs for testosterone, I need to parse out where the testosterone is. Some of it is going to be bound to protein, and that's the total. And then some of it's going to be free, and that's called free, basically. The free testosterone is where the real work is. That's what's really touching cells. That's the most important number always. Single most important is your free. The total, again, as I mentioned, is bound to protein. So when I run her labs, I'm going to see how much of her testosterone is bound and how much is free, but I'm always going to focus on the free because the free does the work. When these patients come in with symptoms, of low testosterone, I want to make sure their free testosterone is not just in the normal range, but I want it to be optimal. So optimal testosterone that's free in women should be between 2.0 and say 4.7, 4.9 picograms per milliliter. And that's using thin layer chromatography, mass spectroscopy testing. That's the fancy way of testing. That's going to be your most accurate way of testing the free testosterone directly and using that reference range. Between 2 and 4.9 for free tends to work real well for me in clinic. I'd see the best results. Say the woman presents to clinic and her free is 0.1, 0.2, and her total is 10, and that'd be like say 10 nanogram per deciliter, which is very low as well. When I see that, I know that I'm okay to prescribe. And
the first step is that I know when I introduce testosterone to their bodies, either where I give them no matter what, the first thing that's going to happen is it's going to be bound. Okay, so your total testosterone for this woman is going to go high. And I expect that. A woman can present to clinic who's on testosterone replacement therapy, and their total testosterone can be very high. It can be 200, 300. I know this sounds heretical. Bear with me. If you have a 200, 300 total testosterone, and your free is 2.8, 3.2, that's what's really in circulation doing things. The rest is bound to protein. It can be terrifying to see that in clinic. Because if you see a total testosterone walk in your door at 300, and it should be no higher than 70 or 80 or whatever reference range you're working on, whatever lab company you have in front of you at that day, you can say that, oh my God, I've done something wrong. If you're a clinician, you don't know what you're doing. It is, again, important that I really want to calm you and comfort you and let you know that the total testosterone that is bound to protein is inert. It slowly comes off of that binding protein, the sexual binding globulin. It slowly peels off and becomes free. The free is where the real work is. So you can have a high total, so long as you're free is within the reference range. You're safe. There's no pathology. That's the first hurdle when I have patients, when I come to clinic, after I started treating them, sitting down with them that first lab review and saying, hey, your total's going to look high. That's okay. I use diagrams, I draw pictures, I just, whatever it takes to explain this to them. And that's how the first step. So I want to affirm to you that if you have lab work done, you see your total being wicked high, don't hold off. I know it's not easy to. Sometimes it's very scary. Hold off. The free is the most important thing. Because once it's free, it's no longer bound to protein. That's what can bind to cells and do the work that's supposed to do. But also, if the free is too high, if you're pushing beyond 5, goes about 4.8, 4.9 into 5, you have a higher conversion rate to something called dihydrotestosterone, which could create way more side effects. So your free is always the thing we watch when we go to treat these women. So our goal with you is to have your free, as I mentioned, somewhere in the neighborhood 2 to 4.7, 4.8, somewhere in that neighborhood. I'm a little fuzzy with the top end of it. I never want to go beyond 4.9. It just, after all these years, you could just see it just never goes well. I've seen enough articles say between 2.0 and 8.0 is fine. I've never been able to give a woman free testosterone above 4 into the 5s without consequence over time. So you want to stay in that tight range, and you want to run your lab work. When do you run lab work? Depends on how you're giving her the hormone. So this is going back to delivery systems. This is another part of this. So we're running your lab work. I know you're low. I want to bring this up. I know that I want your free between 2.0 and 4.7, 4.8, somewhere in that neighborhood, okay? And that's where I want to get to be. My preferred way is always going to be an injectable. And why that is because of side effects, the possibility of side effects. No matter what, when I give you something from the outside in, it's not as good as the original plan. I'm not doing it the same way your ovaries were doing it. I'm not doing it the same way your adrenal gland does it. I'm giving you a surge of it at once. And my goal is to get into the body and make the free level to be high enough to do something beneficial without side effects. So when we do injectable, you have the best conversion of testosterone to dihydrotestosterone. So you're not going to have such a high conversion because you really don't want to make too much dihydro. You want to keep that number below 20 on labs. And some women need to be below 15 even. You're all different. I know some lab companies give you the reference range up to 22. The 20, I prefer below 20. 18 is nice. But again, you're all unique. So when I give you that testosterone and I give it as an injection, I know I'm going to have a certain rate of transfer over to dihydro. So I'm watching that. Say you are on topical, okay? Say you're in a part of the world or in a part of the country where your doctor will not prescribe injection and they're only going to do a gel or a topical. What do? Well, one, we run labs, okay? You deserve labs. Anybody who says you don't do labs with this, I'll do an episode based on labs soon. It's like, I think the next one, it's coming. Why we run labs. When you do a topical, you have a 5.5-fold rate of conversion of testosterone to dihydrotestosterone more than normal, okay? You just will make more dihydro. Dihydro is not a bad thing. I want to let you know this off the top right away. Dihydro is not a bad thing. It's the dihydro that does all the good work in your body. So testosterone goes into the cell. It gets converted to dihydrotestosterone. Dihydrotestosterone in the cell at the right levels, healthy muscle mass. Better blood sugar metabolism because it improves insulin sensitivity. It's really fun there too. What else does it do? It goes up to the amygdala. It has all the benefits up there. It's dihydro, which is estradiol, is your downstream metabolite. You're going to get that benefit from estradiol. Dihydro does all these great things for you. It helps with skin moisture. But if it's too much dihydro, you have oily skin and you start adding more acne, more breakouts. Dihydro also causes more body hair when it's too high. Dihydro when it's too high causes the pattern thinning in women as well as men. Again, it has to be pretty high to do that, but you're all unique. You can't just say, well, they're below 20, they're fine. You have to be a good doctor always and always monitor and sit down and talk to them. I've never seen it happen to someone below 20, but that doesn't mean we shouldn't always be watching the dihydrotestosterone that's below 20. You should always be aware of that for when we watch for side effects, regardless of what you think the reference range should be. Still, dihydro is one of those things that you want, but you need to be very cautious of because when it goes too far, it's not safe or healthy for you for side effects. Vocal cord thickening, that's when your voice becomes thicker, deeper. That's a possibility from dihydro being too high. Libido. All these years doing this, I rarely have had a problem with a patient who had a problematic libido with the dosing we do, but that is possible. It's important as a physician to be aware of that because sometimes, we want a healthy libido in your body, but I don't want the kind of libido where you're like, I'm at work right now. I need to be focused on my job, or I'm at the supermarket. Like, I want your libido to be healthy, but I want it to be in perspective. You know what I mean? I don't want you to be a stressor in your life. The health of the clitoris is a unique thing to discuss. And then, I've said it somewhere else before, when men have low testosterone, we develop something called adult onset micropenis. They'll lose up to a third of leg finger. This happens. And it's fixable with testosterone a lot of times, largely. Not always perfectly, but there's things in there, but it does help. The penis is analogous to the clitoris between the two. And, embryology, they come from the same kind of stem cells at the same starting point. They have similar sensitivities to testosterone. Okay? So when we normalize a woman's testosterone, it's going to have an impact on the clitoris. And we want that. Right? This is an important part of your biology. This is an important part of your identity. This is something that always gets overlooked and ignored. But this is important. Testosterone improves the architecture, the blood flow, the innervation of that tissue. It works better. We want that. We want that. With that said, too much dihydrotestosterone can create something called clitoral megaly. The dosing that I'm going to recommend here doesn't do that. It does not do that. The dosing we do will not lead to. With that said, it's still your body and you're a unique individual. In the dosing range we do, if you notice this becoming a problem where you feel it's swollen too much, it's irritated, it's not being protected by the labia, it's very easy for us to draw back the dose. That will reduce that possible side effect. So being aware of these possible side effects is really important. And running lab work to understand how these labs could trigger these side effects is equally important. Because you want to make sure you're watching for these in your lab work before the patient even notices it, because they say, okay, your dihydro is 21. I know the reference range says 22, but hey, this is a possibility. How's your skin? And how's your hair? How are you? And you go down that history and understanding, making sure that she's not having adverse response to it. So topical, again, back to delivery systems, is not my favorite because it tends to create too much dihydro and it's not easy to manage. Does that mean impossible? No, it's not impossible. It's just trickier. And it just means I need to be more careful, more thoughtful. So how do I do that? Say the patient comes in, her dihydrotestosterone is at 24, and I want to bring it down. Well, I could try lowering the dose, but what if her free testosterone is only 2? And she's concerned and worried that if we lower the dose too much, she's going to lose benefit. What do I do? How do I approach this? I always go back in my head, and we may end up having a lower dose. I'm like, make sure she always knows this. But then I'll also consider doing, something like salt palmetto, and maybe something like salt palmetto. Generally, that's my go-to. It's called the 5-alpha reductase inhibitor. So there's an enzyme that turns testosterone to dihydrotestosterone inside the cell. It's 5-alpha reductase. And that's what creates dihydro. You can slow that down with saw palmetto. 350 milligrams daily, maybe a little bit more. I use some brands more than others. Life Extension, I've used that with good success. And I've also used Mountain Peak formulas that have something called prostate formula. And I know as a woman, you don't have a prostate. But still, this is the same thing with men. Testosterone, dihydrotestosterone causes the prostate to swell in guys. We want to reduce the dihydro for them. Similar concept, so we will use that product. That one works well. And then I run my labs about a month later to verify that the dihydro was brought down into the normal range for that woman. Because you're doing this and you're having benefit and it's going great. If I'm asleep at the wheel as your doctor, not paying attention to the possible side effects, it's only a matter of time before the side effects overtake the benefit and you lose it. And then you throw out the baby with the bathwater. And now you're back to square zero. Like, I don't want to do testosterone because it creates side effects. The reason why I made side effects is because it wasn't being well managed. So we work to reduce down your dihydrotestosterone. Do I use finasteride? Rarely, because it's dicey. Finasteride's a dicey one. That's a 5-alpha reductase prescription. 5-alpha reductase inhibitors as a medication is dangerous because the 5-alpha reductase enzyme is not just present in your testosterone dihydrotestosterone pathway, but it's also in the pregnenolone allopregnenolone pathway. The way you make neurosteroids, you'll use 5-alpha reductase. You use that pathway. And so if you're shutting it down with finasteride, you're going to shut down neurosteroid synthesis, and that's going to create a lot of other symptoms in your life that you don't want. So if we do have to use finasteride, what do? I monitor the heck out of every pathway I can. So I monitor your dihydrotestosterone. I will do the best that I can because you can't run a direct allopregnenolone, but I can do labs indirectly by running a progesterone that's being used in basically ELISA, which is an immunoassay lab of progesterone. And then I use an LCMS progesterone, which tells me how that works. The ELISA enzyme pathway immunoassay lab of progesterone tests not just progesterone, but it kind of lumps into it allopregnenolone, all these other metabolites. So when I run that lab, it's going to be a combined one. So that's why using that one lab, the ELISA lab, the enzyme linked immunoassay, is not always the best, most accurate for progesterone. But it's useful because I can get the metabolites in there with the progesterone. And then I run the LCMS one, which is liquid chromatography mass spectroscopy, which is a much more precise. It just gets just progesterone. So then I look at the difference between the two, and I can infer allopregnenolone that way. That's tricky. That's something you can do. So I would do that if I'm giving you finasteride because your brain is important. Your brain is important. And I want to give you something that's possibly causing neurosteroid synthesis to be diminished that could lead to significant depression, significant long-lasting depression. So whenever I use a medication of that magnitude, I want you to know I will run the labs around that too. Because I care about you as a doctor. This is what we do. This is our role, is to make sure you're safe and to do the hard work it takes to give you a medication that works and that you stay safe with it. Other delivery methods of testosterone, as I mentioned, you have the injectable, which I prefer. You have the topical, which I'm cautious with. There's the pellets. The pellets is a very popular one. And the pellets have a ton of research, and they've been around for a very long time. I do prescribe them, and I do use them, and I do pellet insertions in office frequently. Why I'm careful with talking about it is because once it's in your body, it's there for 4 months. There's no pulling it out. You're just going to have that pellet in there for the full 4 months. It's someone with 3. It depends how your metabolism works. You can't make a choice then. So I don't like to start people on pellets. I like to start you on an injectable first, see how you do with it, and then offer pellets if you want to down the road, because now I know how your body metabolizes it, and I can do the math on figuring out between pellets and the injectable. So I hope this is helpful. What I wanted to get from this is what the lab work should look like, what the reference ranges are, that when you are labbing after you started taking testosterone, that the total is going to be high. But the free is what we should be watching, that we should always watch for the metabolites, the possibility of side effects from them, how to manage metabolites and lowering the dose or changing delivery systems or adding into like salt palmetto or something like that. That's a 5-alpha reductase inhibitor, something along those lines. I hope this helped. I want to reiterate that you deserve lab work. And then after you start protocol, lab work about a month later, make sure that it's the right dose. And then after that, every 6 months, monitoring it, because you will change as a human being. And your needs for this hormone will change. Sometimes you'll need a dose to be higher, sometimes it'll be lower. But it's important that we pay attention to that and run labs consistently. I know I keep saying run labs, run labs, run labs. The testosterone lab work is not $1 million in the States. I think it's like in the $50 range for free total testosterone last time I looked. Which if you're doing that every 6 months, I believe that is a doable thing if you don't have insurance, you're using cash price labs. I keep talking about lab work. It's not because I'm trying to charge, $2,500 every 6 months. Labs don't cost that much. There are ways of getting really well-priced labs. So labs, you deserve good care. You deserve a doctor who spends the time monitoring your metabolites so that they keep this safe from you is non-negotiable. You deserve that 100%. I hope that helped. To the degree that it did, let me know. Like it, share it, subscribe it, and if it isn't, send us a comment. I'm always open to your feedback, and I want to grow and learn to be better at this. So thank you again, and I'll see you at the next episode.